right, let's get Grand Round started. Good morning, everyone. So one of our chief residents is Dr. Olanrewaju, otherwise known as Buki. And Buki is one of our chief residents, and she is planning to stay on our faculty when she finishes her residency. And so we're very happy about that. And so she picked a very interesting subject, which I hope the first part is the correct part, to vaccinate or not to vaccinate. This is certainly a problem that pediatricians are facing across the country, all primary care physicians, family practitioners as well, because there are some families who are doubting the benefits of vaccine, and I think she's going to give us a nice presentation of the state of the situation and what's potentially fueling this and how to approach it. So,
thanks, Dr. McKinney. Good morning. Like Dr. McKinney said, I'm Dr. Olanrewaju. It's a mouthful, but everyone calls me Buki because that's so easy. So I wanted to do this topic because I found it very interesting. Many people know I come from Nigeria, and it's a developing country. A lot of people do not have access to vaccination. And so coming to the US and seeing that it's widely available and people are refusing was kind of strange to me. And so one of the things for me as a pediatrician was whenever I met patients who were refusing to be vaccinated, I really wanted to understand, some of the reasons, because culturally it differs from place to place and countries to countries. So I really needed to understand what people were worried about to be able to address the concerns properly. So I have no disclosures. My objectives really are to highlight the importance of vaccines, and I'm going to be giving some historical perspectives. We will be discussing some common vaccine concerns. Bear in mind there's so many, but I will be focusing on just some for the sake of the time of the presentation. And we're going to be discussing some ways to effectively communicate with these parents. So no doubt, vaccines are one of the greatest success stories of public health. As a medical student, we do a rotation called community health, where we go into the community and we actually do like public health, really going around seeing, safe water, vaccination. We actually engage in vaccination campaign. We go with the people vaccinating and we just kind of help in doing that. So it's really a huge public health issue. And, a lot of us, thankfully, we never met smallpox, especially my age group. We've been able to eradicate smallpox, and we're getting close to eradicating the wild polio virus. People are no longer developing, devastating effects of these infectious diseases, and so people are like, a lot of people I've never seen, especially, maybe my age group in America, I've probably never seen someone with polio before. And so people are wondering, do we still need to be giving these vaccines? And people are worried about, vaccine safety and why are we even doing these vaccines? So a little bit of history about vaccines. Edward Jenner is considered the founder of vaccinology in the West. And really, they say in the West because in the Far East in those days, the Buddhist monk would sometimes drink snake venom to kind of give them some kind of protection against snake bites. So they were practicing some sort of vaccination then. And what Edward Jenner did was in 1796, he actually took his gardener's son and inoculated him with cowpox virus. He had noticed that the milkmaids were not what contracted cowpox virus, did not develop smallpox. So he took this little boy, inoculated him with cowpox virus, and some months later inoculated him with smallpox virus and realized that he did not develop smallpox. And that was how he kind of found out, there could be some sort of thing we could use to prevent this. And subsequently, the first smallpox vaccine was developed in 1798, and due to mass implementation, mass vaccination, we're able to finally eradicate smallpox virus, smallpox globally in 1979. Vaccine hesitancy is not something that started recently. It's not something Jenny McCarthy started. It's been here all like time immemorial. From when Edward Jenner started this practice, people were worried, like, how dare you inoculate something from an animal in a human being? Why are you messing with God's creation? If you got smallpox, maybe God has a reason for it, just let it run its natural course. And of course, one of the concerns we still have in this day and age is the optimal balance. Why are you forcing us to vaccinate? If I don't want to, I should choose not to. So those were concerns in those days as well. I'm going to use a polio example as about one of the success stories of vaccines because polio is actually very personal for me because my little brother My mom had missed some of his vaccination while he was young, and I can still like keep playing that image in my head. I can still remember that morning when it was just, we usually wake up and just play in my mom's room in the morning, and we're just playing. It was a toddler, and he just fell. He just had acute flaccid paralysis like that, and we found out he had polio. Thankfully, he is one of the few people that recovered. He recovered. He's very healthy right now. And so, you know, polio is a very devastating disease. It can leave you with severe paralysis. And more than 35,000 people a year in the United States, in the 40s and 50s, were actually, you know, getting crippled by polio. And imagine this: when people are crippled, it's not just, imagine the loss of economic life, because they probably now have to depend on the government. They cannot go about their daily activities. Thankfully, we got the polio vaccine in 1955. Polio has been eradicated in the United States since 1979, but we still have it in some parts of the world. And people need to remember that because polio is not totally eradicated from the world, it just takes one person with a wild polio virus to come into the country. And if we're not protected by herd immunity, then we're just going to have another outbreak, which is why we need to emphasize and make sure we keep our vaccination rates high. And this is just the CDC. I found this on the CDC to kind of just give you an idea of the burden of polio. And we can take a look. In 1988, this is the entire African continent with the burden of polio. Now, because of immunization, this is 2014. Polio is totally, you know, off the African continent, off the American continent. Just so in Africa, we have it just in Nigeria, which is still endemic, and we have it in Afghanistan and Pakistan. Now, one of the reasons why we still have polio endemic in Nigeria is because of vaccine hesitancy, because people have the myth that, especially in northern Nigeria, that if you give your child vaccines, you're sterilizing them, and it's the way of the white man limiting our population. And so people are refusing these vaccines, and people are hiding their children. And some people even go to the extent of kidnapping these vaccination workers, because vaccination workers just go around in the community and try to vaccinate kids. So people are actually laying down their lives to get kids vaccinated. So it is a serious thing. People would not be doing that if it weren't very important. And I just had a little trivia. Who knows which American president was paralyzed by polio? Exactly, Roosevelt. And it's interesting because he actually got it as an adult, which is not very common, but you know, he did good. And who knows what this guy is? Benjamin Franklin, yes. So Benjamin Franklin, one of the founding fathers, very intelligent man, but in his day, he was actually one of the anti-vaxxers. He was very against vaccines, and unfortunately for him, his 4-year-old son, whose name was Frankie, I found that very interesting, died of smallpox. And then he wrote about how he actually regretted, and you know, he really should have weighed the benefits and the risk, and probably should have gotten the smallpox vaccine, which is one thing we also need to be reminding our parents, that you know, you need to weigh the benefits and the risk and all that. And every time, the benefits of vaccinating your child always outweighs the risk. Why is this important, and why should we be talking about this? There are increasing number of parents who are either delaying or refusing the recommended vaccination. We have the school exemption immunization laws, which allows some people not to vaccinate their kids, and they go to school with the rest of us who have our kids vaccinated. In Louisiana, we do have the philosophical exemption. So there are 3 exemptions people can have depending on what state you live in. It varies from state to state. You can have religious, philosophical, or medical exemption. Louisiana, we have the philosophical and the medical exemption. However, if your healthcare is funded by the state, if you're on Medicaid, then you are not allowed philosophical exemption. The American Academy of Pediatrics recommends that only medical exemptions really should be allowed, because we have kids with leukemia, immunosuppressed children, and we just need to kind of protect them as well. And you know, like we talked about, if we're not keeping up the herd immunity, we're at risk of getting infected, getting infection towards kids that are either too young to get vaccinated, people who cannot be vaccinated for medical reasons, like our immunosuppressed children who cannot get some vaccines, or some people just do not develop enough immunologic response to vaccines. I remember growing up, we did not get the routine hepatitis B vaccination. So I got the vaccine when I got to med school because they wanted us to get it before dealing with patients. And one of my colleagues, so after the 3-dose series, they usually do a titer to make sure we have enough, you know, we've developed enough immunologic response. And one of my colleagues, it just did not develop immunologic response to the vaccine. Is a healthy kid, is normal, nothing's wrong with him, but it just did not develop it for some reason, and we don't know why. So there are people who would get vaccinated, but they may not develop enough antibodies. So we all need to keep our vaccination rate high so that we can protect these people. There was a case control study done by the Kaiser Permanente group, and they did this over an 11-year period of time, and they found out that people refusing vaccines were about 23 times likely to get a pertussis infection, and people refusing the varicella and pneumococcal were about 9 and 7 times increased risk of getting the infection. So it's not a small percentage it is significant, so we need to keep this in mind. There was a survey in pediatrics, and which showed about 300 pediatric residents, and only about 49% said they received some sort of training about communication strategies with us parents. We go through residency, we meet different patients refusing vaccination, but we don't really have a specific sort of training on how to address these issues and how to talk to these parents. And about 80% of them really wanted to be educated about vaccination. They really wanted to know more about adverse events, because if your patient has gone to read something online and you're not aware of possible adverse events of these vaccines, then you really cannot communicate well with them because you don't even know what they're talking about. So it's important that we know this thing so we can better communicate with our patients. This is just a little graph that kind of shows us the evolution of, vaccine acceptance. And really, whenever you have your incidence of disease, when it's really high before vaccines, vaccines are developed, people start getting vaccination, disease starts dropping. And because more people are getting vaccinated, of course, we're going to see more people with adverse events. So the focus shifts away from the disease onto the adverse events of the vaccines. People lose confidence in the vaccines and your vaccination rate drops. And of course, there's an outbreak and people say, oh no, we need to get vaccinated. They start vaccinating again. And hopefully the goal is always to get to eradication. And once we eradicate a disease, then we really do not need to vaccinate anymore, like smallpox. It's been eradicated. And if we can eradicate the wild polio virus from the world, then we wouldn't need to be giving the polio vaccine anymore. I wanted to mention briefly about vaccine safety and monitoring. There's a lot that goes into vaccines before they're actually licensed. There's a pre-licensure, there's during the trial, post-licensure, and it can be a whole grand round on its own. But I wanted to focus on these 4 main program that the CDC does. So the vaccine adverse event reporting system is just really this report where if you suspect any adverse reaction to vaccines, you can report to the CDC. The beautiful thing about the system is anyone can report, be you a parent, be you a physician, a nurse, anyone who suspects, you can report, and the CDC would investigate it. The vaccine data link system is really a collaboration between the CDC and the 9 major healthcare big organizations, and this is actually the 9 major groups in the US that does the vaccine safety data link. And what they do is they do continuous research on vaccines. So some of the information we get from the vaccine adverse event reporting system, they're the ones who are going to analyze it and really conduct research on it and see if there's an adverse event. And it's worth mentioning that it was through the vaccine adverse event reporting system that they were able to discover the link between intussusception and the rotoshield vaccine, and so that vaccine was taken off the market. The Clinical and Immunization Safety Assessment Project is really another, major health centers and CDC, they conduct research, they look at special populations. So if you have, maybe a patient with a special disease that you're not sure about vaccine safety, you can ask them. The beautiful thing is that you as a physician can contact them and they can act like a consultation service for you. And of course, the emergency preparedness for vaccine safety is really when in a case of an outbreak, for example, and we need to vaccinate people massively, we're still interested and we still want to make sure vaccines are safe. So they are in charge of making sure in a case of emergency, the vaccines we're giving are still safe. So it would always be worth, if you have a patient who's probably very educated, wants a lot of information, telling them about the vaccine adverse event reporting system, that way they may have some consolation that we're not just throwing them high and dry. There are things in place to ensure vaccines are safe. In talking about vaccine safety, we also need to acknowledge that their vaccines can have risk as well. You establishing this with your patient really increases and improves your credibility. You're not just saying all vaccines are good. Vaccines are not without adverse effects. We take Tylenol. Tylenol has some adverse effects, but we take it anyways because we know the benefit outweighs the risk. So we need to talk to parents about this, but put it in context. Most adverse events are really self-limited. They're very minor. Serious adverse events can occur, but they are exceedingly rare. Can you have a patient that can have an anaphylactic reaction to a vaccine? Yes, but that is exceedingly rare. One good example would be measles vaccine. Measles vaccines, can it cause encephalopathy? Yes, but what is the risk? It's 1 in a million. If you get the measles virus itself, your risk of getting encephalopathy is 1 in 1,000. So you getting the vaccine, you have 1,000 chance less than getting the than if you didn't get the vaccine. So we need to kind of put this in context and kind of just explain to parents, yes, vaccines, you know, they're not 100% safe. We're humans, we're not perfect, you know, we're still doing lots of studies and research, but you at least acknowledging this makes your patient trust you more, and your credibility is actually more important. So now, what is vaccine hesitancy? According to the WHO, it defines vaccine hesitancy as a delay in acceptance or refusal of vaccines despite availability of vaccination services. And it's a behavior influenced by a number of factors, which includes issues of confidence, which is a big thing in the US, where people do not really trust the vaccines, they do not trust the providers, they do not trust the pharmaceutical company, or issue of complacency, where people just think, oh, we don't have, you know, we have clean water, why should we get rid of virus? You know, those kind of things that people say sometimes. So, you know, they just don't think it's important. Or issue of convenience, which is really the extent to which people have access to vaccination. Are they having issues with transportation? Are they just not able to afford vaccination? And some of those things. I went to medical school in Ghana, and vaccination is actually free across board for every child. But in Nigeria, you have to pay for some. So with parents in Nigeria, if you don't really have money, then it becomes an issue because you may not be able to vaccinate your child very well. And so I will be focusing a lot about confidence and complacency, but we'll talk a little bit about the convenience as well. There was a periodic survey of fellows conducted by the American Academy of Pediatrics in 2006, and it showed that 75% of pediatricians had encountered parents who refused vaccine. And they did a follow-up study in 2013, and the figure had actually increased to 87%. So it means almost 90% of pediatricians, so we're saying 9 out of 10 pediatricians are saying people refusing vaccines. So it's a lot. And the pediatricians reported that patients who refused 1 or more vaccines increased from 9% to about 17% in the 7-year period. That's almost double. So it's something, you know, we're seeing and we need to address. So the recommendation by the American Academy of Pediatrics is that we continue to engage these parents and continue to talk to them. We should continue to provide health services to these children and attempt to modify their misconceptions. But recently, in August of last year, the AAP has actually agreed that dismissal as a last resort, if you've done everything. Previously, the AAP did not recommend dismissal, but now you can actually dismiss if you feel like this patient, you've been trying everything and it's really not working and they're a danger to other patient population you have in your clinic. What are some characteristics of vaccine-hesitant parents? They're more likely to be Caucasians, they have higher level of education, higher income. They usually live in a state that allows some sort of philosophical exemption from the school immunization law, and most times they think they can control their child's exposure to diseases. This is interesting because I met a patient once who refused the flu vaccine, and when I asked her why, she's like, well, my child doesn't go anywhere, she stays home all the time. And so I asked her, I said, well, do you go grocery shopping? She's like, yeah, but I don't take her. I said, did you sit in the waiting room when you got here? She's like, yeah. I'm like, so even if your child is not going anywhere, you're going out and you're coming back and you're bringing things into the house. So your child can still, even though she's not going out, you're still bringing things into the house. A lot of them are worried about being good parents. They're worried about their child's developmental milestones. And, you know, they're really information seekers. A lot of them are on Google. They've done their researches. And so they're coming to you with questions. So we really need to be prepared. Vaccine-hesitant parents are not a homogeneous group of people. They're really heterogeneous, so we need to put that in context. We have parents that would usually sometimes accept every vaccine without any questions. Some people may accept, but they're not really sure. Some people want some alternate schedules. Some people are refusing, but they don't even really know why. And there's some people that are just adamant and everything is bad and they're just refusing. And these are usually the ones that are very difficult to deal with. So we need to put it in context that when people are hesitant about vaccine, don't lump them up together in a box. Some people really, it's just ignorance. They just even don't know. Like, I remember a patient I saw in the ED who came in with a child who diagnosed with the flu. And she asked me, and she refused. I said, did you get your flu shot this year? She's like, no, I didn't want it. And so when I told her her child had the flu, she said, well, how did she get the flu? Could it be from the bug bites? And I was just shocked, bug bites. So it just showed that she really did not understand what the flu was, but she refused the flu vaccine. So we need to kind of put it in context. So that kind of patient, it's not really that she wanted to refuse, but she really did not understand the consequences when she was refusing. And we probably didn't spend enough time really educating her and correcting her misconception. Why we worry about vaccine hesitancy is usually because those patients, especially because if they live in a state with philosophical exemption, they're usually in clusters, and this increases vulnerability to diseases. We can remember the measles outbreak in 2015 in California. So we need to kind of, and majority people would actually vaccinate their kids, but those few people that are not vaccinating, when they're in clusters, it increases your chances of outbreak, and that's why we really worry about this. So what are some of parental concerns? People say, you know, disease no longer exists. Why should I vaccinate my child? We're overwhelming their immunity. Why don't you let them have natural immunity? Some people are complaining that we're giving too many shots. The shots are too painful. And of course, people have concerns about some of the vaccine components. For vaccine-specific reasons, I will be talking about flu vaccine and people saying they're going to get the flu, the HPV and increased promiscuity, and of course the MMR and autism. This presentation would not be complete if I did not talk about this. So some of the specific concerns. If people say diseases no longer exist, we need to remind them that the reason why diseases are not existing is because vaccines have been crucial in doing a good job in helping eradicate some of these diseases. And remember, we live in a global world. Remember the Ebola outbreak. It started somewhere in West Africa, and some random guy, you know, hopped on a plane, and before you know it, is here in the US. You're like, what are the odds? What are the chances? But we live in a global world. There's a direct flight to Nigeria from Atlanta, from Houston, from Dallas. So it's just one flight away. So people can bring things from anywhere. So we need to, you know, keep up with our herd immunity, because this is really what protects us. When people say vaccines overwhelm the immune system, they've done several studies and there's no really strong evidence to support this. Children have an enormous capacity to respond to multiple vaccines and other challenges. That was a study I read from the Institute of Medicine, and they said that 1 URI, a child is exposed to about 4 to 10 antigens. Now, take the average school-age child who gets about 8 URIs in a year. That's a lot of antigens, but what they're even getting from vaccine is even nothing close to what they're getting from URI. So we need to put this in context for our parents. If anything, vaccines actually boost your immune system, because when you get vaccinated, then your body is able to produce all these antibodies. So when you do get an infection, your body is actually prepared to be able to act and fight against these diseases. When people say we're giving too many shots, it's true we're giving more vaccines than decades ago, but it's because science have advanced. We have vaccines for some diseases that were killing children in those days that we did not have vaccines for. We have advancement in our protein chemistry such that even though we're giving more shots, they're getting fewer antigens. So back in the day, a smallpox vaccine would give you about 200 antigens. But now, if you calculate the 11 vaccines we're giving to children under the age of 2, they're getting just less than 130 antigens. So it's actually fewer. Previously, people were getting wholesale pertussis. We're no longer doing that. So it's actually better. Even though it looks like it's more shots, it's actually less antigens that they're being exposed to. And some parents, of course, are just concerned that this is painful. Why would you do this to my child? We need to work with them. The American Academy of Pediatrics really recommends that, you know, you can administer these shots quickly to children without having to do, you know, try not to be too dramatic. You're pulling back. If they're babies, you can swaddle them. You can give them some sooties. When I used to take my child for vaccination, I actually used to put him to breast, and as I was breastfeeding, it would get his shot. It would cry a little bit, but then just continue sucking again, and it was fine. I remember when I brought him for his flu shot, they assumed it wasn't going to stay still because it was a toddler, and they just came and held him down. I'm like, oh my God, I can imagine what parents felt. But you know, there's so many things. We have Child Life. You can call Child Life to help you with so many distraction techniques to help with this. So it doesn't have to be a painful experience for the parents. We can work with them to see how we can minimize pain for their children. And of course, you can always give the most painful shot. You can always give that last so that it doesn't become too traumatic for the child. Some of the vaccine-specific concern, the MMR and autism. This really started with a 1998 case series by Andrew Wakefield, who was a gastroenterologist. He actually did a case series on 12 patients with inflammatory bowel disease, and he said that he made a hypothesis that the MMR vaccine damaged the intestinal lining and that it would lead to encephalopathic proteins crossing the blood-brain barrier. This was published in The Lancet. 10 of the people who co-authored this actually retracted their statement. They found out that they falsified some information, and unfortunately it took too long, and it was retracted in 2010, but the damage was already done. Even though it lived in the UK, it had already spread across Europe, across America, and people were refusing MMR vaccines. So until today, the damage is still ongoing. There's still people who still believe that MMR caused autism, unfortunately. And so in 2010, they finally retracted his report. Unfortunately, Dr. Wakefield, even his license was also revoked because of, falsifying information. And so we need to put this in context for our patients and really explain to them this is not true. So many people tried to reproduce the same thing and they could not even reproduce it. Some of the children he had even surveyed, they found that some of them already had regression in their milestones, and they had changes even before they got the MMR vaccination. The CDC also did a study in 2013, and they showed that MMR really does not cause any form of autistic spectrum disorder. What they did was they looked at a number of antigens and the body's immunologic response to that, and they found that there was really no difference between kids with the autistic spectrum disorder and those without it. A lot of people truly believe this because I know some, healthcare workers who actually say, oh, this, I believe this happened. Unfortunately for the MMR vaccine, it's really a victim of timing because we give it at a point where that's when you really start to notice your child's developmental milestone, their social skills. It's really that point where you start to see. And it was interesting, I was reading this blog of one of a family medicine physician. She's actually on the doctor's show. I don't know if anyone watches it. But anyway, she was talking about how she met a mother who had triplets, and as soon as they got their 6-month shots, they regressed, and she thinks it's a 6-month shots. And she was talking about how I didn't know vaccines were this terrible. I'm sorry I gave it to you. When physicians say things like that, it really underscores our journey. And I'm so surprised because I'm like, what are you even talking about? This is a case of triplets. We don't know. We know that multiple gestation is high risk. Could these kids have some sort of placental insufficiency? At the 6-month visit, could that have been when they started to show signs of maybe cerebral palsy? There's just so much that you don't even put into context, and then without any research, without anything to back it up, you have a platform, you put it out there. And I know people, really talking about, oh my God, I can't be, I'm so scared. The doctor said it's not good. I'm not going to vaccinate my children. And so we need to be careful before we put some statements out there. The flu vaccine. The biggest thing people say is if I get the flu vaccine, I'm going to get the flu. No, you won't get the flu. The flu vaccine is an inactivated virus. It cannot cause an infection. We need to explain this to our patients. A lot of them think the common cold is the same as the flu. No, it's not the same. It's totally different. Anyone who's ever had the flu knows what it's like. And I just came back from vacation in Atlanta, and I was talking to one of my friends that I stayed with. She's a family medicine resident at Morehouse. And she was telling me whenever she moved to the US at first, she didn't get the flu shot. And she got the flu, and she told me it was the most miserable time of her life. That not even when she got malaria, it was so miserable. And you really would know if you've ever had the flu, you would know that it's really not the common cold. Unfortunately, we give the flu vaccine in the winter season, which we're already very snotty. I'm sure people are already sniffling. We all snotty already in the winter, so people think, oh, I got the flu after I got the flu shot. No. If you really had the flu, it's really difficult to explain to people, but you really need to have the flu to really know what it feels like. And so they're not going to get it. It is protective and it's helpful, and we really need to encourage patients to get the flu. One of the things we can do is don't start talking about the flu vaccine when the flu season gets there. So for your patients, for example, if you have a 4-month-old who's getting their 4-month shots, and when they come back for their 6-month shots, it's going to be the flu season, you need to bring it up to the patient. The next time you come, baby's a big girl, she would be getting the flu shot. That way, if they have any concerns or if they say, no, I don't want it, you can have some discussion. Even if they don't agree at that point, by the time they come for the 6-month checkup, you can solidify your discussion and they may agree at that point. But if you bring it up at that point, sometimes they just don't agree and they just don't come back. And the CDC had some interesting statistics about the flu. The economic burden of getting the flu, it contributes about $31 million outpatient visits in the flu season, 200,000 hospitalization, and we're losing about $87 billion. Imagine that. That's a lot. It's not something that we can just pass over. People think, sometimes when you tell people, they say, oh, the flu season is over. No, we're in March, it's still flu season. As long as the virus is circulating, we should be encouraging people to get the flu shot as well. The other thing people worry about the flu is egg allergy, and this is a new recommendation from the CDC for the 2016-17 flu season, which I'm pretty sure may come out in our boards or next IT. So previously, if you had egg allergy, they recommend you get the flu vaccine. They watch you for 30 minutes before they let you go. The recommendations have changed. Now, if you get only hives by eating eggs, you can administer the flu vaccine without, any consequences. Now, if the person has some sort of anaphylactic reaction when they take eggs, then you can still give the flu vaccine, but it should be administered by someone trained in recognizing anaphylaxis and managing it. So previously, it had to be a physician to administer it if you had anaphylaxis, but now even a nurse can administer, but you have to make sure your nurse knows how to recognize signs of anaphylaxis and how to treat it emergently. So you can administer it and just, in any way, outpatient, inpatient, you don't have to keep them for 30 minutes anymore. So just food for thought, because they may be asking us that in our exams. Of course, the HPV, a lot of parents are worried that if they give their children HPV, it's going to cause promiscuity. Now, for me, when I was a medical student, I saw a lot of cervical cancers. And the common denominator with all these women, they were very celibate. They did not, they did not have any partners aside their husbands, but their husbands, either they were in a polygamous relationship or, their husbands were cheating on them. That was a common denominator. So even if your child remains celibate, you're not guaranteed that the person that they will be with could have been celibate. So if the person they're going to be with has the virus, your child still has a chance of getting the virus. Imagine if there was a vaccine for breast cancer. Are we going to refuse that? So a lot of times physicians are not really giving stronger recommendations on HPV because of they said it's sexually transmitted, we're not comfortable. Some parents say they're not yet ready to talk to their kids about, this kind of things, which is okay. If you don't want to talk to your 11-year-old, you can still get the vaccines without really laying down all the details, and as they get older, you can, talk about it. But we need to be recommended the HPV strongly. Fortunately for us in Louisiana, for females, we have about 60% rate of vaccination, at least one dose, which is, not too bad, but we can do better. The goal is to get at least 80% or more. And so we can do better. So we really need to, HPV is one of those things that when we see, we're just like, oh, it's just HPV. We just go like, it's just HPV, it's just HPV. Like if we see someone hasn't gotten meningococcal, we'll be like, you have to get it before you go. But if it's HPV, we just go, it's just HPV. We really need to be recommending this strongly because it is about cancer prevention. And this is just an amazing graph. For cervical cancer alone, this is the ones associated with HPV. So of the almost 12,000 cervical cancer, about 11,000 is from HPV. So it's a big deal. And no one ever wants to hear the word cancer. No one ever wants to be diagnosed with cancer. It's such a terrible disease that if we can prevent it, then we really need to be preventing this. And, luckily too, the CDC came out with new guidelines for HPV for children less than 15. Instead of the 3-dose series, we can do 2-dose series for them. So that may be reassuring for parents so they don't have to come back multiple times. And of course, if they're 15 to 26, then they have to get the 3-dose series. But we're hoping they can come up with, if we can get everyone down to a 2-dose series, that would also be good. So some vaccine component concerns, which I actually did not really think much about until I started researching this topic. One big one is Thimerosal, which is really mainly ethyl mercury, and people are worried. They're like, oh, they're putting mercury in our vaccines for children. Ethyl mercury is so different from methyl mercury. Methyl mercury is the dangerous one that at toxic levels can cause problems. But ethyl mercury is different. It's like methyl alcohol, ethyl alcohol. Methyl alcohol is antifreeze. That's very dangerous. But like ethyl alcohol, a lot of people drink it. That's regular beer. So we need to kind of put this in context for patients that they're totally different structurally. And it's really been used as a preservative in vaccines. And the reason they use it we used to have multi-dose vials to prevent bacterial growth. And really, the most common risk is really if you have some sort of hypersensitivity. It doesn't cause problems. People were worried that it caused some sort of autism. It doesn't cause autism. It was actually taken out of childhood vaccines between 1999 and 2001 as a, just as a measure, as a precautionary measure by the CDC to really decrease the level of, any mercury exposure to children. And even after it was removed, the CDC continued to do studies to find out if there was any relationship between autism and this mercury, and they still found that there's really no association. So we really need to explain this to our parents and tell them it's been removed from all childhood vaccines. Some flu vaccines still have ethyl mercury in them if it's a multi-dose vial. But if your parent is really worried about them, you can say, we will give you a single dose vial. You can kind of negotiate with them to kind of ease some of their concerns. People are also concerned about aluminum in vaccines. Aluminum is a naturally occurring, element in the world. It's everywhere. It's in soil, it's in water, it's in formula, it's in breast milk, it's everywhere. We cook with aluminum foil all the time. Nobody makes a fuss about it, and they hear aluminum in vaccine, and there's this huge problem. It's been used since the 1930s. It's a very common metal. Small amounts are really just added to help our body stimulate a stronger response to the vaccines. And the amounts present in vaccines are so low that the FDA has actually done studies that if you take the amount a child gets from breast milk, from formula, from the water they drink, and the vaccines, it's still less than the threshold of what the body can handle. So it's really minute compared to what we're worried about, because I cook with foil like every day, so I don't know, which I'm sure most people do as well. So we really need to just reassure our parents and tell them, it's really small, it's not a problem, and we don't need to worry about this. It's just, I think it's just the word aluminum, but people don't think of aluminum foil as well that we use every day. And so we're going to be talking about some strategies. The American Academy of Pediatrics recommends, a presumptive approach versus a participatory recommendation. Now, not that every patient is different, so we have to do different approaches to different patients. You have to individualize your patient. What might work for patient A might not work for patient B. But with the presumptive approach, it's very easy, straightforward. You're assuming they're going to get the shots. So you just say to them, it's time for flu vaccine today. You give it, done, go. We need to give your Tdap today. Give it, done, go. Now, some people you can say you need to get your flu today, and they go like, oh no, I don't want it. Then you may have to go for a plan B. A participatory approach is when you probably say, oh, have you thought about the flu vaccine this year? And so the patient goes like, that's true. Then they start thinking, and you start engaging in this conversation. So knowing your patient population, if you think the presumptive approach is better, just go for it and get it out of the way. But some patients would not buy that, and then you need to go to another model. So there's the CASE model, which was developed by Alison Singer with the Autism Science Foundation. And the American Academy of Pediatrics actually also recommends this approach. So the corroborate is, for example, your patient tells you, I'm worried about MMR vaccine. I think it's going to cause autism. And you can say, so you corroborate what they say, but you don't acknowledge it as being right. So you can say, I've had a lot of parents also mention that same concern. You don't say, oh, you're right, that's a common, you don't validate what they've said, especially if it's wrong. And then about me is you kind of give them a little bit of background about yourself. This is not to brag, but to show that you didn't just go to Google and get your degree. You can say, I went to a conference last week, and I actually saw Dr. Buki, who's an expert on vaccines, and he said this and this and that. And I actually read the new CDC recommendation and guidelines, which said, to show that you've done some research and you know about the topic. Then you talk about the science behind it. You can say, the Centers for Disease Control actually did a study and showed this and that. Just kind of, and really this will probably be for if you have a very educated patient who really wants all the information. And then explain and advise, and then whatever that concern is, you hone in on it and you address that specific concern. There's another strategy I found, which was out of Washington State, because they had a lot of kindergarten kids who were not getting vaccinated because Washington State allows philosophical exemption. So they came up, different health organizations in Washington came up with this strategy. I find it kind of easier to do than the CASE approach. But like I said, you have to individualize your patient, which is really ask, what is your concern about vaccines? Do you know what the vaccination schedule is? And you can provide this for the patient. And when they tell you, empathize with them and acknowledge their concern. Don't belittle what they say, because we like it or not, even though people think, oh, how can you just not vaccinate? In the parent's mind, they're looking out for the best interest of their child, and we really all want the best for our children. So you need to empathize with them, and you need to acknowledge their concern, and then whatever specific concern they have, you answer that specific concern. Try not to go through the whole spiel. If a patient is worried about, oh, I'll get the flu if I get the flu vaccine, focus on that. If a patient is worried, oh, my child will get a fever after vaccination, focus on that. And you know, sometimes they want more information than you can expand depending on how the discussion goes. It's really important for pediatricians because there was a publication in Pediatrics where more than 7,000 children aged 19 to 35 months were surveyed, and you know, they asked the parents what role they felt their primary care physicians played in them deciding to vaccinate, and about 80% of them stated their decision was positively influenced by their primary care provider. So if 80% of parents are looking up to us to really guide them, we need to do a better job. We need to be up to date, and we need to know how to discuss with this patient. We need to initiate the dialogue about vaccines very early. Actually, there's some studies that say, you know, even right from the obstetrician visit, and I know in some private practice they have what we call a prenatal visit. So when patients come, you know, to establish they're looking for a pediatrician, you can start talking about vaccines at that point. And if they have, you can offer them the vaccine information sheet, and you can actually, you know, if they can read that and come back with questions if they have it. And the CDC actually recommends that every patient that gets a shot gets a vaccine information sheet. You can always give it to them early. You can, you know, talk to them about it. That way, if they have a question, you can start this dialogue early, so that by the time it's time for the vaccine, you've really done everything, and you can go ahead and just give the shots without any problems. You need to welcome questions. You need to say, for example, what questions do you have about vaccines, rather than do you have any questions? So sometimes the way you frame it kind of makes it easier for the patients. And of course, you know, it's tough, especially if you're in private practice, outpatient, you're working real hard, you have so many patients to see. It's kind of annoying sometimes because you're like, I don't have time for this, but you really need to try. Majority of patients are not anti-vaxxers, remember that. So those few that are really refusing, you need to just try to spend a little bit of time with them to kind of just, you know, understand their concerns and address it. So don't get offended, and try not to be offensive to them as well. We need to personalize the information. You need to know what your patient literacy level is, and just keep it simple. Clarify their misconception. Discuss the benefits of vaccines. If you have personal stories, you can share it with them. I remember one patient we had once a 7-year-old kid who came in, had never been vaccinated, and he had an open fracture. It was a dirty wound, and I was talking to the parents about vaccinating, and they were refusing. And I know one thing the father said to me was, can you assure me 100% that if you give this vaccine, my child is absolutely going to be protected? And I said, you know, I was really feeling smart. I was like, oh, you shouldn't have asked that. I know the answer for you. And so I told him, I was like, you know, we wear seat belts all the time, and there's no guarantee that if we get in a wreck, we're not going to get some sort of injury. And he looked at me and said, well, that's why I don't wear seat belts. And I'm like, and his wife looks at me and says, help me on that one. And I'm like, oh my God, I don't know what to do. And so one of the ways I was able to convince them was really to share stories of kids with tetanus that I had seen back in Nigeria and how devastating it could be. And even though we couldn't convince them, they got the immune globulin, which they refused. They didn't get a tetanus vaccine just because the only one we had was the smallest was the TD. And they said, we want just tetanus. And I called pharmacy, and we really couldn't get just tetanus, and that was why they refused. But you know, it wasn't very, I wish they had, but it was still something. And so we can share personal stories with them. And we need to always discuss the state laws, because if your patient, there's some parents that are not vaccinating their children because they really believe in herd immunity, and they're thinking, well, other people are vaccinating, so I think my child's gonna be protected. They wanna feed off the rest of us. But if you're living in a state that allows philosophical exemption, and a lot of people are not vaccinating, your child is not protected. So we need to really discuss this with them, and they need to know what they're getting into before they choose not to vaccinate their children. And of course, the AAP recommendation on dismissal is really, you've exhausted every means of education with the family, you've told the family about your policy, and you're living in a geographic area with no short supply of pediatric providers. I just don't know where you would find that in the US. There's always a shortage of pediatricians. And you also continue to provide care for these children for at least 30 days till they find a new provider. And really briefly about hesitancy due to access, which are the people who, it's not really because they don't want to get vaccinated, but they're not able to afford it, or they don't have transportation to come. The American Academy of Pediatrics recommends that you can review your orders and you can vaccinate at every time, like every visit you see this child. And we do an excellent job of that here. You live in the hospital, you need this, we give it to you. You come for a snotty nose in the PIDS clinic, you're not up to date on shots, we vaccinate you. We're doing excellently on this. You can also review office policy on physical exams. So for example, flu season. If a parent was having difficulty with transportation, has to come and probably has to work 2 jobs, has to come and sit down for 4 hours before they get the flu shot, then they would really weigh the benefits and like, I won't get the flu shot, I'll just wait. So if you can make it such that you really don't need a physician to see this kid, they can just come in, get the flu shot and get out, it makes it a lot easier, and we're probably going to get better coverage. And of course, you can create vaccination-only appointments. So you can tell patients, we're going to be doing only vaccine-only. If you have, complaints, we're not dealing with that. We're doing shots-only visits, and we're going to be doing it between 7:30 and 10 a.m. And your patients come in, wasting time, get their shots, go out. It's a lot easier, and people would likely bring their kids rather than having to stay so long waiting to get just shots for their parent. And with our patient population, we know that sometimes transportation can be difficult. In summary, we need to always acknowledge whatever concern these parents have. We need to always discuss the benefits and risk of vaccines using very clear and simple language. The key thing is really addressing specific concerns. Try not to get into too much argument. Hone in on that specific concern and try to deal with it. And most importantly, we need to really respect the parent's authority and develop this ability to have a shared decision-making style. That way they know that you're looking out for the best for their kids as well. That's my references. Questions?
A great presentation that covered the subject really well. Excellent job. Questions? So, Buki, one of the things that parents are doing sometimes is asking you to change the schedule, delay the schedule. How do you approach that?
So with the parents asking for alternate schedule, we need to be very emphatic in our response that the Advisory Committee for Immunization Practices, the American Academy of Pediatrics, they put out a certain schedule because there are different diseases that affect children at different age groups. So we need to get them vaccinated at a certain time. And they haven't done any study to find out that the alternate schedule is actually better. Now think about if you had to do, some people, for example, they want to come this week and get the shot, they want to get another one. It's waste of time for the parents as well because it results in multiple visits to the pediatrician when you can just get the shots at one time. I think for me personally, one of the things I do, for example, the 12-month shots, which you can give between 12 and 15 months. A lot of parents are really concerned that we're giving 5 at the 12-month visit. So if it's a patient that you know and you know that they're very, they come, I negotiate with them. And so, for example, if I give the MMR, varicella, and maybe HEB at 12 months, when they come at 15 months, I give the rest. So that's still within the recommended schedule. So we can, you may want to do that, but really just results in multiple visits for parents. If you offer alternate schedule, they have to come make multiple trips, and it's not really recommended by the Advisory Committee for Immunization Practices.
Well, one of the things that some of the women heard me say, but so, they can't get the flu shot until 6 months, and by that time, if they're on time, they've gotten their Hep B at birth, they've gotten 2-month vaccine, 4-month vaccines. And so, one of the things that you can ask of parents is that, you state to them, so your child got 2 polio vaccines, 3 Hep B vaccines. Did they get polio from the vaccine? Did they get hepatitis B from the vaccine? And then you just tell them it's made the exact same way. It's the exact same kind of vaccine. They're not going to get the flu from the vaccine.
One of the big things to remember when you split vaccines up, I've had some inpatient, like the nurse was like, I don't want to give 6 vaccines. And they gave MMR one day and varicella the next day. So one thing to remember is that you have to give the live ones all at the same time. So just making sure nurses realize that stuff as well, that splitting them up can cause harm or result in even more vaccines, maybe not harm, but.
Yeah, that's true. You have to understand the rules, and to give a live vaccine, you have to wait 28 days before you get the next one. So that's really important. You can give inactivated vaccines one after the other, but not live.
I've heard some private practice people talking about just like the logistics of getting shots. If you don't have a big practice and you're not in the VFC program, that it can be costly. Did you come across, or in your experience, Dr. McKinney, do you know any people that have just not given shots in their clinic nowadays?
I didn't understand.
So I was like at Mid-City, Peds, where they see a majority of private insurance patients. They were saying that they barely break even on their shots, and so cost-wise. And is there, other than the BFC stuff, is there another thing that you can recommend people doing, or?
Well, the AAP has a great deal of guidance on how to address issues to be able to not lose money when you vaccinate. And actually, probably one of the biggest expenses for an office today is your stock of vaccine. I mean, a big practice is maybe $500,000 of vaccine that's sitting in the refrigerator and the freezer. And you have to work out appropriate ways to try and buy the vaccine at a reasonable price, make sure it balances against what you're being paid for per dose, make sure that there's not a lot of waste. When you drop one dose of HPV vaccine on the floor, that could change your ability to make a profit. So all those things need to be taken into account, but you can nobody gets rich off of vaccines. I mean, you're doing it because it's a public service and you're helping your patients, but you want to be able to make sure that you don't lose money doing it. And so there are ways to do it. The Academy has, for every vaccine that you give, they have a guidance and implementation set of that's available that can help you put it into your practice without losing money. But that's an important factor.
Many pharmacies also now administer shots. Okay, what about if the pharmacy is close to the patient's home and it's convenient? What would be your thoughts on?
So, actually just filled out a survey yesterday for the Louisiana, I think, American Academy of Pediatric chapter, looking into, should we, to be able to capture more people, especially for vaccines that people refuse, like the flu vaccine, to just let pharmacists administer that. And they were really looking at, what age group is it okay for. So, I mean, for a teenager, I don't think it should be a problem, but, and if we're advocating for no physical exam, just let them get their shots, I don't see why it should be a big deal if we're going to achieve that coverage and given the economic burden of the flu. But I think I'll probably look at when they come out with their results to see what the recommendations would be.
Yeah, and I think flu is different than every other vaccine because you have to get it every year and you have a limited time span within which to give it. And the issue about getting vaccines outside of the medical home is that when you see a child for routine care and vaccines are part of that, then you're doing many other things for that child at that visit. So if you give up the visit by having the child get the vaccine outside of your office, you can't do the rest of the anticipatory guidance and the other things that are needed on a regular basis for kids. And so that's a dilemma with making the pharmacy the primary place for all vaccines. And so that's a real issue, and I think that you got to think about how that fits into your practice and how you like to use vaccines as part of evaluation and management of routine visits for kids. So that's always an important consideration. Okay, other comments? If not, Buki, thanks. That was great.
Thank you, Dr. McKinney.